component, Doctor? No, there it is. Good afternoon and welcome to our Orthopedics and Sports Medicine Lecture Series. I am Dr. Rogelio Uribe, Corporate VP of Baptist Health International. It is my pleasure to welcome you all to this informative presentation. I would like to extend our warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the pleasure of introducing Dr. Juan Suarez. Dr. Suarez is an orthopedic surgeon at Baptist Health Orthopedic Care, part of the Baptist Health South Florida network. He specializes in adult hip and knee joint replacement surgery, including revision, joint replacement, and minimally invasive surgical techniques. He is a board certified orthopedic surgeon and has more than 16 years of experience in his specialty. Dr. Suarez received his medical degree from the University of Puerto Rico School of Medicine in San Juan and was inducted into the Alpha Omega Alpha Medical Honor Society. He completed a residency in orthopedic surgeon at Jackson Memorial Hospital, University of Miami Miller School of Medicine, and a fellowship in adult hip and knee reconstruction at Ortho Carolina in Charlotte, North Carolina. Prior to joining Baptist Health Orthopedic Care, Dr. Suarez was affiliated with Cleveland Clinic, Florida in Weston. Dr. Suarez has made numerous symposium presentations on the efficacy of surgical methods utilized in hip and knee reconstruction. He's also widely published in such scientific publications as the Journal of Arthroplasty and the American Journal of Orthopedics. He serves as an affiliate assistant professor at Florida Atlantic University, Charles E. Schmidt College of Medicine, and on the editorial board of Arthroplasty Today. He is a member of the American Academy of Orthopedic Surgeons and the American Association of Hip and Knee Surgeons. Please, let's give a warm welcome to Dr. Juan Suarez. Doctor?
Thank you, Roger, and thank you for this generous introduction. I'm gonna go ahead and share my screen. Welcome all the participants. I tend to enjoy more interactive stuff, so if you have any questions and Roger sees it in the chat, Roger, you can stop me at any time and I'm happy to answer anything as we go along. So let me share my screen here. So I was asked to pick a topic of my choice, and I thought that, technology and joint replacement could be a good one because, it can give you a flavor of what we're doing new and how that is impacting the care of our patients. So today I'm going to talk a little bit about technology, both on the hip replacement side and the knee replacement side. And I picked three specific things that I think are making a difference in what I do today. So I don't know if you know, but hip replacement was termed the operation of the century by the Lancet, which is one of the biggest journals in the world. So it's a very good operation. And traditionally the bearing surface has been either metal on polyethylene, as you can see, or ceramic on polyethylene. But, when we talk about technology, I don't think we've been the most responsible people in the world adopting technology or creating technology. And, a couple of examples are, at one point, we thought that if we did metal on metal hip replacements, that would last longer because the joint would wear less. And what we found that it was a terrible idea. Metal on metal eventually ended up failing early, and we ended up, hurting patients instead of helping them. In a similar way, we went from monolithic stems for the femur to modular stems, where you can see that the femoral neck, it's modular. So you can change that and adjust that to different anatomies. So we thought that it was a good idea because then we can accommodate better different anatomies. And what we found, unfortunately, is that when you have dissimilar metals joining each other, if you have a titanium stem and a cobalt chrome neck, then you end up with corrosion issues like you see here. And then that becomes a disaster where patients have corrosion and metallosis and all that kind of stuff. So, the point of me saying this is that I am not a person that adopts technology early. I let things play out a little bit. before I decide. I think that, a lot of the, the FDA has flaws in it in their system. So not everything that's FDA approved is actually safe on the long run. So we have to be mindful of that when we adopt technology. But, I think that I'm going to talk about 3 technologies now that are proven and have, and are good to patients and improve the outcomes of patients. And I'm going to show you the data on it. And it's some things that I've been using for quite some time. And the 2 things that have changed, I think, my practice is having intraoperative information or intraoperative data, whether that's navigation or robotics. Having information in surgery has definitely changed the way I do my surgery. And also the application of 3D printed materials has really been a game changer in the realm of orthopedics, especially hip and knee replacement. And I'm going to give you a specific example of that. So in terms of intraoperative data, so this is a patient with a left-sided hip replacement. And, when you look at a hip replacement like this, there's a couple things that you want to make sure you get right. One is the cup position or the angles of the cup. And it matters because that can determine if the cup, if the hip becomes unstable or not. Also leg length. You want to make sure that you recreate the leg length of the patient appropriately. One of the main reasons for litigation in the United States after hip replacement is over lengthening the leg. So that's important to us, and also offset. So this is a case where you can see that the hip was dislocated because the cup position was off. The angles of the cup was off. So we need to make sure that when we do this operation, we know that we're putting the cup in the right position. And this is a study out of Mass General where they looked at the ability of those surgeons to put the acetabular component in the right position. And in only 50% of the time, they were able to hit the target zone. So this is Mass General, Harvard surgeons, and only 50% of the time they were able to do it. The reason is because they were doing a posterior approach and the patient is on the lateral position. So they really don't know where they're putting the cup because the patient is moving in surgery. So if you're using just extramedullary guides or using anatomy, you may get fooled and you don't know it until you get an x-ray in recovery room or after surgery. The way we do the surgery is through an anterior approach. The patient is supine, meaning that it's easier to use fluoroscopy or x-ray in surgery because you have the patient leveled in the operating room. The incision is in the front of the hip, and the patient is laying on its back. It's not laying on its side, and that's an anterior approach. But the benefit is this: you can use fluoroscopy, meaning you can use x-ray in surgery, so you can see real time where you're putting the implants in, the orientation of the implants, and the leg length and offset that you're recreating at the time of surgery. So immediately intraoperatively, you know where you're putting the implant. And this is different than a posterior approach where you put the implants in, you take the patient to recovery room, you get an x-ray, and it is what it is. This way, you know exactly what you're getting. And, when I was at the Cleveland Clinic, we published a paper on our first 1,600 patients anterior approach and our ability to hit the target zone in the acetabular component. And what we found is that we were able to hit the target in 95% in abduction, 95% in anteversion, and 92% combined. And these are pretty good numbers. This is without using any more technology, just using fluoroscopy and our intuition based on what we're looking at x-ray. And this numbers held true even on obese patients, because we know that obesity is an independent risk factor for component malposition. And what we saw, we stratified our patients in different BMIs. And what we saw was that even on patients with a BMI of over 30 or even 40, our accuracy of hitting our target with the acetabulum was maintained. So again, anterior approach, use of fluoroscopy definitely helped us achieve our target zones, and that translated into better outcomes because less risk of instability, less risk of dislocation. So in addition to that, well, the technology that's coming out now is fluoroscopic based navigation. Not only you can look at the fluoroscopy image and be like, well, I think this is in the right spot, but now there's navigation systems that are incorporated into the fluoroscopy and can give you specific information, specific data about what you're putting it in. So for example, in this case, you put the cup in, and then the system will tell you where your numbers are 38 degrees of inclination and 17 degrees of aversion. So you have specific numbers to make decisions intraoperatively. And this is very useful because when you don't have something like this, there's a little bit of guesswork in the sense that, well, I think this is 40/20, but you really don't know. But this puts a number to your intuition. And then the other thing it can do is give you information in terms of your leg length and offset. For example, you take an x-ray or a fluoroscopy view with the trial implants in, and then what it does, it superimposes your pre-surgery image to the intraoperative image and superimposes both of them. And then it gives you information in terms of, well, in this case, you're lengthening 2 millimeters from where you started, and you're increasing the offset by 15 millimeters. And then it tells you, well, if you change this or that, it'll translate to these numbers or those numbers. So again, intraoperative information for intraoperative decision-making, so you can hit that target that you're looking for in surgery. And to me, this has been a game changer because it eliminates guesswork. It eliminates the amount of patients that dislocates. It eliminates the amount of patients that come to your office saying, well, you left my leg too long or too short. So you, again, it makes those outliers disappear and everybody more in the center of that bell-shaped curve. And you can take this to another level in terms of incorporating in spinopelvic dynamics. We know that the pelvis moves as a patient goes from a sitting to a standing to a laying down position. The pelvis of a patient moves. And when the pelvis of a patient moves, the cup orientation also moves. It's not static. And this is an example, right? When the pelvis rotates backwards, you can see that the orientation of the acetabulum component also changes. And when the pelvis moves to the front or anterior, you can see that that cup orientation also changes. So again, it's a dynamic environment, and that dynamic environment is affected by the balance between the spine and the pelvis. And now we have technology that by obtaining a couple of x-rays before surgery of the patient in the lateral position, you can see, well, in this patient, if I put the cup in 40 degrees of inclination and 20 degrees of aversion in the supine position, that'll translate into these numbers in a seated position and these numbers in a static position, standing position. And it also can quantify the risk of that patient dislocating based on some parameters. So now this is fluoroscopy on steroids, right? Now you can start looking at where you're putting the cup. What would that translate in a sitting or standing positions, which are the positions at risk for dislocation. And now you're able to make better intraoperative decisions and better intraoperative execution. And now when you put the cup in surgery, it not only tells you you're here, but it'll tell you, if you look at the left-hand side, it'll tell you we're in the seated position, you're going to be here, and the standing position here, and it'll change the colors depending on whether you're at risk or not at risk of having a dislocation or an instability issue. So that's from the hip side. If there's any questions about that, I mean, Roger, you can fire them now, or we can keep going.
I think we keep going, and we'll tackle in the end. I'm sure folks will be ready by the time you're.
So on the knee side, traditionally, we used to do knees with manual instruments, and the goals of a knee replacement has always been kind of the same. You want a well-aligned total knee replacement. You want a well-balanced, so it feels the most natural as possible to the patient, with properly sized implants. And traditionally, good alignment was zero mechanical alignment, which means if you drew a line from the center of the femoral head to the center of the ankle, it would pass right through the middle of the knee, meaning that it would be like a straight leg. And we would use mechanical or manual instruments, meaning we would put a drill hole on the femur, set up an angle on this, put big pins on it and cut through it. And we the same thing with the tibia. We would put a tibial alignment guide, and basically we would eyeball it and see, well, this is 0 to me, and this is where I'm going to cut, and I think I'm cutting 2 millimeters. And so there was a lot of eyeballing in terms of the operation, a lot of craft and arts to it. And then you would, look at the alignment with a rod and say, well, yeah, I think this is straight. And then you would put these big clamps to tension the flexion gap to give you an idea of the laxity of the soft tissues, both on the medial and lateral side. And then that way you would make the knee replacement if you thought it was adequate, without much information and surgery to alter that decision making. You would just use your intuition and your feel. So what we've been doing for the last 3 years is doing robotic knee surgery. And the robotic knee surgery, it helps you with alignment. It helps you with soft tissue balance. And then because it's accurate, you can use bony cuts to help you with both alignment and soft tissue balance. That way you can start personalizing the knee replacement for the patient, right? If you think about it, my eye, I can see neutral mechanical alignment. I can see 90 degree, but if I want to cut that in 3 degrees this way or 2 degrees this way, I don't think my eye is sensitive enough to be able to pick that up. So if I cut 3, I may be cutting 7, and then I have an outlier. So it's very variable. And there's one big study out of Ortho Carolina that showed that when you do knee replacements with manual instruments, you can have up to 30% outliers in terms of way off in the numbers that you were aiming for. So this is an example. You get a CT scan of the patient's knee, and once you're in surgery, you register the knee in surgery, and the system basically marries the CT scan to the intraoperative field. And then it starts with a boiler template or a traditional way of doing a knee replacement, and it'll give you the size of the implants, and it'll tell you we're cutting at 0 here, we're cutting at 0 here, you're going to be taking 7 millimeters of bone here, 3 millimeters of bone here, 8 millimeters here. So it gives you a plan that is kind of boilerplate or standard. And then what you can do with that plan, then you can stress the knee, and it'll give you soft tissue balancing numbers, like these numbers here: 18 millimeters, 19 millimeters in extension, and in flexion, 14 millimeters and 17 millimeters. And I don't want to confuse you with the numbers. All I'm saying is that it'll give you, based on that start, it'll tell you where the balance of the knee would be. And at that point, then you can start making adjustments of the cuts and the alignment and rotation of the implants to satisfy the soft tissue balance that you're looking for. Therefore, now you're not only relying on the art part of it, but you can execute it with accuracy, because you have a robot that if you tell the robot you're going to cut this in 3 degrees, you can cut it in 3 degrees with a lot of confidence. And then once you're comfortable with what I call the virtual surgery, you bring in the Mako, the robotic arm, and the robotic arm does the cuts for you. Obviously, you push, it puts it in plane and you control it, but it's controlled within a haptic boundary. For example, if you look at this image here, the green line here, that means that the cut won't go past that line. The blade won't go past it. And it's, and once you cut the amount desired, that green will go away and turn white. So it helps you plan the surgery and execute the surgery and give you information in terms of soft tissue balance. So, and then it's very powerful. And this is a good example of why is it powerful. Like, this is a patient that had this osteotomy in Cuba, which is the incorrect operation. They did a varus producing proximal tibial osteotomy. So if you see, they changed the joint line dramatically. And if you're doing this operation with manual instruments, it's very difficult because you don't have a lot of play in your eye to determine how to cut it. But with the Mako, what we were able to do is we said, okay, so we're going to cut the femur in a little bit of valgus, and we're going to cut the tibia in a little bit of varus and maintain that obliquity. That way, I don't have to do another osteotomy to correct the deformity. And it also avoids me having to take the complete plate out. So it allows me to do the surgery, change the angles that we routinely do, make them a little bit off in order to satisfy the patient's anatomy. And that way you personalize the surgery. And this is the plan that we had. These were the soft tissue balance numbers that we got. And then this is the execution. As you can see, we cut the tibia in about 4 degrees of varus. We cut the femur in about 4 degrees of valgus. We were able to keep the plate in. We just had to remove one of the screws. And, you know, this surgery was very, very easy to do with the robotic assistance. And, you know, one of the things that I've learned over the years is once you trust the robotics and knee replacement, the stress level when you go into surgery diminishes dramatically because you have a lot more confidence now. You have data, you have information to help you do the surgery. And this is a paper that was presented at the Knee Society last year that measured the surgeon's stress based on perspiration and vital signs. And what they found is that when they looked at surgeons operating with robotics versus non-robotics, their stress level was a lot less when they were using the robot. And I think that's important. You know, I do about 700 surgeries a year. And if I can have an instrument that decreases my stress, it's I think that's a winner for me for sure. And lastly, the other technology that has been a game changer for us has been the 3D printed materials. And you know, it's material that's very porous, a lot of friction, and resembles the trabecular bone of human beings. And you know, the porosity is very high, a lot of friction. And what that allows you to do is use these materials for press fit or non-cemented applications, because that amount of friction prevents micromotion and stimulates bone ingrowth into the implants, promoting biological fixation, which is more durable than cement fixation. One of the things that you can do with 3D printed materials is you can create any shape or form that you want with it. So you can create, you know, you can put it wherever you desire to put it on the implants, and you can make any shape that you desire. For example, for patella replacements, and on the tibial side, you can put it wherever you want the material to be at specifically. And why is this matters in knee replacement? So we know that the longevity or the survivorship of knee replacements is not the same for everybody. If you look at the left-hand curve here, the green is patients below 55. So as you can see, the failure rate or the risk of revision on patients under 55 is a lot higher as you move along time than on patients that are greater than 65. So obviously there's something off on these younger patients that put higher demands on knee replacement. And also on obese patients, if you look at the purple line here, the risk of revision is higher than the non-obese population. So again, young obese patients, the survivorship is not the same on knee replacement. And the reason for the failure is fixation. And this is a data out of the Australian registry that has demonstrated that the number one reason for failure and revision long-term is aseptic loosening or failure at the fixation junction. And that's all because of cement. So these patients with younger patients that have cemented knees, after 10 years, their failure rate spikes. And this is a graph that tells that. So the purple line is cemented and the red line is cementless. So you can see that on patients under 65 years old in the American Joint Registry, the risk of revision is higher as you move along time on cemented knees than on non-cemented knees. And why is this? Because what's happening is that these new 3D printed materials were able to do these cementless knees with more confidence and more predictability in terms of the biological fixation that's occurring at the interface. This is a picture of a cementless knee on the back. You can see it's all coated with bone. There's bone ingrowth in the entire surface of that knee replacement. You know, and when you don't use cement, you're faster in surgery. If you're faster in surgery because you're not waiting 20 minutes to cement cure, the risk of infection goes lower. The longer you're in surgery, the higher the risk of infection. It's cost neutral because the implants may be more expensive, but you're not using cement, which costs money, and you're less time in the operating room. You don't have to use a tourniquet, which is one of the main pain generators for the knee replacement, because it doesn't matter if it's bleeding or not the bone. You can put these with confidence and it's not going to matter. And it's going to provide long-term biological fixation. And as you can see on the American joint replacement surgery, this is the blue line, and this is the utilization of press fit knees in the United States. As you can see, it's going up exponentially in the last couple of years. And it's over 10% of the knees that are being put in the American Joint Registry. And these are recommendations from the American Academy of Orthopedic Surgery. This is evidence-based recommendation. And what they found is that both, at least at the short term, cemented and cementless knees perform equally. Cementless is not inferior. And actually on younger patients, there is a real benefit to performing press fit knees with biological fixation because they will last longer. And I'm going to leave you, a lot, I give these talks sometimes, and there's a lot of old school surgeons that will tell me, I don't need fluoroscopy to do a hip replacement because I'm good enough. I don't need a robot to do a knee replacement because I'm good enough. I don't need none of this technology. But, I don't know how many years ago we were riding horses and stuff. We ride like cars now that are like battery operated. So I think there's a normal evolution in society. And I think we can use and apply technology in a responsible and a very effective way. And I'm going to leave you with these words from the founder of Apple, Steve Jobs, because it's a very interesting way that he was thinking back in the 1980s about the use of computers in society.
I remember reading an article when I was about 12 years old. I think it might have been in Scientific American, where they measured the efficiency of locomotion for all these species on planet Earth. How many kilocalories did they expend to get from point A to point B? And the condor one came in at the top of the list, surpassed everything else. And humans came in about a third of the way down the list, which was not such a great showing for the crown of creation. And but somebody there had the imagination to test the efficiency of a human riding a bicycle. Human riding a bicycle blew away the condor, all the way off the top of the list. And it made a really big impression on me that we humans are tool builders, and that we can fashion tools that amplify these inherent abilities that we have to spectacular magnitudes. And so for me, a computer has always been a bicycle of the mind. Something that takes us far beyond our inherent abilities. And I think we're just at the early stages of this tool, very early stages. And we've come only a very short distance, and it's still in its formation, but already we've seen enormous changes. I think that's nothing compared to what's coming in the next 100 years. So
this is in 1980, computer, the bicycle of the mind. Think about it, how far we've come. Everything is on a phone now. So again, I think there's been a lot of reluctance to applying technology for surgery. And I think one of the issues is cost, and we got to be cost conscious. But on the other hand, we have to strike a balance of how we apply technology and how we use that technology to be better surgeons and get better outcomes. And, I pride myself that I have adopted technology responsibly. I am affiliated with an institution that has supported our endeavors of adopting technology. And, the good thing about this, that is at the end of the day, is that our patients that have benefit from this. And I hope this lecture or this talk made sense to you all. I hope it inspires you and creates curiosity. And I'm glad to take any questions.
Thank you, doctor. Amazing. And, you know, there was a time that you didn't have access back in the day to a robot. And then if somebody didn't speak about it in front of you, you didn't have that, I want to learn more about this, and then to be able to get involved and start using it, right? And so this is what I love about these conversations, just like the Da Vinci robot, because the more we talk about it, the more we talk about how to use it, where to use it, when available. Whenever it's available elsewhere, there's already a lot more information than when you all started using it, right?
Yeah, so, you know, that's a great, when I was at the Cleveland Clinic, they were in the infancy of buying a robot. And I let my former partner use it for like a year, and then I went to visit him. And, you know, I went to visit him twice. I saw him in the OR, and I had a conversation with him, and I started to see the benefits of it and understand why he was so passionate about it. And there's always a little bit of fear of the unknown. You know, you're in a routine, and you're like, well, I got to get out of my comfort zone. But at the end of the day, I mean, this has been a game changer for me. I just can't say it it's been a game changer.
You know, Rob, Baptist, you said it correctly. The institution always tends to invest into technology. I think we were one of the first to have the Mako in our area of all hospitals in Miami. And that really proves to the point of getting experience with top level, I would say, technologies. One thing is technology, and the other part is to learn how to use it. And then the other part, doctor, is the volume. You know, can you talk about, you know, just like with the Da Vinci robot, now for you all using your robots, if you don't have the volume to have the practice of doing this over and over again, you know, how much does that affect you and how good you're at it, right?
Yeah, so, you know, I just published a book chapter on learning curve on anterior approach. And it's interesting. I did a lot of research of learning curves. And the number 40 keeps coming over and over, no matter what subspecialty we're talking about. But now, if you do 40 in a month, it's not the same as you do 40 in a year, right? The repetition is important. Interestingly, though, the industry tries to promote. So let me backtrack. So the majority of the joint replacements in the United States are not done by high volume surgeons. And the intention of industry is to help those lower volume surgeons be better surgeons. But what I found is you take a person like me that's a higher volume surgeon and you just get to another level. But yeah, I agree that repetition is important. You have to be able to stick with the learning curve, and you know, you can't just dabble in it. If you just dabble in it, it's just not going to be, you're not going to get to where you need to get to. I think there was a question in the chat about whether it's, I mean, what's the breaking point of it making money? And that's an interesting question, because I don't think you can look at robotic knee replacement as a money maker in the sense that you're going to make more money in the procedure itself, because there's going to be more cost to the procedure. So you're adding cost, but I do them faster. My knee replacement volume has gone up dramatically because it's word of mouth. People love it. So you get more volume, but can I tell you we're going to make more money out of each independent operations? I don't think that's the case. A lot of the purchases of these are attached to volume and rebates.
I think that question was from Dr. Carlos Romero, an orthopedic surgeon in El Salvador, according to what I see here. And, you know, maybe I'm going to try to answer this a little bit in Spanish, pero doctor, al igual que en lo que es el Da Vinci, en el volumen y en lo que es la calidad, eso es lo que nos ha traído a nosotros, más que todo en la rentabilidad de un equipo, es el volumen que se puede hacer, la cantidad de cirugía que el doctor Suarez podrá hacer en un periodo de un mes con la ayuda. Yo le diría, doctor Suárez, menos desgaste en usted como cirujano, Yo creo que eso es todo parte de la rentabilidad. And I'll repeat it in English. What I was trying to say is he was asking how, cost consciously for the robot and the volume. Unlike most places, we don't charge extra for using a higher technology. Usually Medicare does not create, right, doctor, a different code just for
there is a code
for the physician component, right? For assisted.
Yeah, there is a code that not all insurance plans pay for that code, but a big proportion of them do.
But that's under not the facility side, but under the physician side. Is that correct?
Yes.
It's the same with the robotics for Da Vinci, right? We get a laparoscopic code, you get the same type of code, and the technology is provided at the same price. So I think I would say, doctor, it's like you said, right? It's a commitment to quality and excellence, which will bring you the volume, right?
Yeah, definitely. I mean, it's, there's a lot of, if you look at it just as a capital expense, you're going to be a little bit narrow-minded. I think that you need to see the big picture. And the big picture is that, robotics is here to stay. There's no doubt in my mind that I do a much better job with the robotics than without it.
So we're going to go a little rapid fire here, if you don't mind, doctor. And then it says, there's several questions that add up to the same. What factors do you take into account to decide between a knee replacement and the robotic procedure?
So I do,
from Guatemala.
I do 99% of my knee replacements with a robot. So I'm biased about that. So I'd say it's very rare that I don't do it with a robot.
How does the robot affect your length of stay, doctor? And from the moment the patient has their first appointment to from the moment after surgery, how long does that take? And then physical therapy, how long would that take? And what would be the normal return back to their country time?
So the big push in the United States now is that people go home the same day after a joint replacement, whether that's a hip or knee replacement. So I would say about between 60 to 70% of our patients go home the same day. And then when people are international and they're going to go back to their country, we need them to stay in town for at least 2 weeks to make sure the wounds are healed before they go back home. We don't want to have any wound healing issues before they go back home. So, we have this data pretty accurate. So from the time the surgery is done for the patients go home that day is about 3.5 hours, assuming everything goes as planned. Sometimes there's anesthesia issues and stuff like that, but typically 3.5 hours from the time the surgery ends to the time the patient go home. They get walked by physical therapy and everything, and then they can go home.
Quick question from Karen Hides in Cayman. Thank you for attending, Karen. Good afternoon. I am a 55-year-old female. I have been told that I need a hip replacement as the cartilage in my right hip is completely gone. Is this surgery less invasive, and what are the chances of blood clots after surgery?
Okay, so that's two separate questions there. One is an anterior approach is definitely less invasive because you don't have to cut the muscles to do the operation. You work between the muscles. So it's a little bit harder, and that's why not everybody does it that way, but that's how we do it. And it's definitely less invasive. So less pain, quicker recovery, and quicker regaining of your normal gait mechanics. In terms of the blood clots, the risk obviously then it becomes lower because you're moving quicker, right? So the risk of developing a blood clot after a primary hip replacement on a standard risk patient is about 9% of a blood clot, not a pulmonary embolism, just a blood clot in your leg. But the quicker we move the patient, we keep the blood flowing, and that diminishes the risk of blood clots from forming.
Thank you, doctor. And then we have a question from, I believe, El Salvador. Let me see here, Mr. Uprimi. I just want to make sure I get this right, doctor.
I can read it here.
Yeah, Mr. Uprimi. So he's, can you, I had leg purchase from 7 to 12 years old, age of old. I have a shorter 20-millimeter leg from then. I have been suffering from pain in the hip. At Baptist, they gave me a shot for the pain, told me it would last for about a month, 3 months, or years. I've been feeling good for almost about 2 years, but I'm starting to feel pain. What can be done for me? Can the length be corrected?
Yeah, so, in terms of what can be done for you, I mean, you're probably a candidate for a hip replacement when the symptoms merit it, right? Having a hip replacement or a knee replacement is a quality of life decision that the patient makes when everything fails. I mean, if you had a long-lasting relief from the injection, you can try another injection if that's your preference. Or, if the x-ray merits it, you can get a hip replacement. And definitely part of the operation is adjusting your leg length. We typically don't recommend lengthening 2 centimeters because you won't be happy, because you've lived short for so long that if you drastically change that by 2 centimeters in a surgery, you'll actually feel longer than you are. But that's definitely something that gets adjusted in surgery.
Thank you, Doctor. A question here. Mr. Chacon says, great presentation. What is your office or phone number, email regarding making an appointment? We have an international team that's just for you. The email for the international team is very easy. It's international@baptisthealth.net. And our phone number is 786-596-2373. We will write it now in the chat. And it'll be there available later. And we will connect with Dr. Suarez's office. And this is something we do every day. It's our bread and butter. And we're proud to work with Dr. Suarez. And he takes care of many international patients for us.
There's another question by Regina here about using robotics and how hard to learn. And like we discussed, there is a learning curve to everything. But I think this is a learning curve that if you stick to it, I think about 40 cases is the number that you start feeling really comfortable with it. And there's people that are better than others. There's no question about it. So, that factors in as well.
You want to take on the next one, which seems to be just around the same thing?
Well, the robotic, the industry certifies you. You have to go to a cadaver lab for certification of it. But it's not that regulated in the sense like a Da Vinci is, a Baptist and stuff like that you need to be proctored. So this is more of an industry way of making sure that you go through the proper training prior to start using it. And in our facility, then that becomes part of the credentialing process for the physicians.
And last question I see here is, in the case of arthritis in the knee and bone on bone, at what stage do you recommend surgery? Will a knee replacement eliminate the arthritis? What is your opinion of 3 gel injection series or stem cell?
So, assuming that the knee is bone on bone, hyaluronic acid or the gel injections, they could help. It's unpredictable. I tell my patients, that's 50-50. You may have a good results or you may not have any good results with it. And I don't discourage them for trying it because, people have to be really convinced that they are at the end of the line in terms of their pain before they decide to have their knee replaced. In terms of stem cells, the literature is very, not very good. It's not level 1 evidence in terms of its benefits. We have seen some cases of infection and adverse reactions from stem cells, so you got to be careful about it. I don't encourage that much. And in terms of what to expect from knee replacement, so, knee replacement is a good operation to alleviate pain. It may not make your knee feel like your knee felt when you were 18 years old, but it'll alleviate pain. That is the main indication. So the more symptoms somebody has before surgery, the more room for improvement we have with surgery. So we got to make sure that the criteria and the indications are there before we decide to have surgery.
I have a question, doctor. There's always that first doctor that tried something that nobody else tried. Why do you think the first person that tried the anterior approach and other people were doing it differently? What do you think were they trying to just get there separately? I mean, you say it's a more difficult surgery. What do you think was the genesis of that?
So the genesis, this was pioneered in Europe, and it was because they started to do acetabular fractures with it. They developed a special table in France, and they were doing hip periacetabular work in the table through a Smith-Peet approach with it, which is an anterior approach, which is more extensile. And then people started saying, well, maybe we can do a hip replacement through this approach. And in the US, kind of the pioneer in this, and my mentor is Joel Mata, he's at Vail, Colorado now. And in the around 1993, he started doing it here in the US. And it's interesting because he was seen like an outlier, like nobody, he would get criticized so much back then, and he was not part of the establishment. And he persisted, and at the end of the day, I think he ended up winning the argument here.
You all do also a lot of research, right, Dr. Suarez, with your team?
Yeah, we do a lot of research. I've done a lot of research with anterior approach. If you look at every year at the American Association of Hip and Knee Surgeons, they pool the audience in terms of what percentage of them are doing anterior approach. And back, you would say 10 years ago, it was only 15%. Then it went up to 20, then 30%. And now it's about 50%. In Latin America, the adoption has been lower. And one of the reasons is because we use it with a special table it's costly. And there's been an access challenge there for colleagues in Latin America. And, I've trained a lot of them. Some of them do it off table. It's a little bit more difficult, in my opinion. It's not impossible, but that's been one of the challenges.
Yeah, we do a lot of observerships, right? For physicians, orthopedic surgeons that are interested. And so if at any time, any orthopedic surgeon that's actually logged into this, if you reach out to us at the email that we provided at the end, we have a whole program. It's not a fellowship, but if you want to come down and meet with Dr. Suarez, all depending on his schedule and calendar, but we make it available. It happens all the time. And so just wanted you to know that is available. Doctor, I think that's all we have, the questions we have. And I think we had some great, I think that's one of the most orthopedic video conferences with some of the most questions that we've had so far. So we've had a very entertaining audience. And I'd like to say that on behalf of Baptist Health International, I would like to thank you, Dr. Suarez, for this informative presentation and all of today's participants for your attendance. If you have any additional questions about today's presentation, please feel free to email them to us at BHIWebinars@baptisthealth.net. Once again, BHIWebinars@baptisthealth.net. We can do any connections, any questions for Dr. Suarez as a follow-up. Again, if you need to reach us for patient care, our email is international@baptisthealth.net. Same thing, but just international. We look forward to seeing you at our next Orthopedics and Sports Medicine lecture series, which is scheduled for Wednesday, September 7th, 2022. We thank you again. Hope you have a great afternoon. Stay safe, and we see you on the next one. Thank you, Dr. Suarez.
Thanks for having me. Appreciate it.